A very warm good afternoon from sunny South Africa. Good morning to our colleagues in the US. But wherever you are on the continent or in the world, thank you so much for taking the time to join us today. My name is Candice Bailey, and I am the Strategic Initiatives Editor at The Conversation Africa. Today is the final virtual event for 2024 at The Conversation Africa. We've hosted five for the year, and this is the last one. This time round, we've partnered up with the O'Neill Institute for National and Global Health Law at Georgetown University, where we are discussing a very important issue. We're talking about how Africa is tackling health emergencies. Now, the discussion comes on the back of the Mpox outbreak that's spreading across the continent. At the moment, there's a lot of work being done to ensure that the outbreak is contained. But we've got a fantastic lineup of guests and experts who are going to tell us exactly what's happening. I'm not going to get into too much of the weeds because of the conversation is actually going to be moderated by the wonderful Professor Lawrence Gostin. Professor Lawrence, are you there? Good morning. How are you?
I'm doing great. How are you, Candice? I know it's not morning with you, but we're just so delighted to be working with you in the Conversation Africa, and we've got an incredible panel for today.
Now, Prof, I'm going to come back to you in a little bit. I just want to provide a few announcements for our audience, and then we can take it from there. Colleagues, the first thing that I need to tell you is that today's event is being live streamed on the LinkedIn pages of both the Conversation Africa as well as the O'Neill Institute for National and Global Health Law. You can find the stream on those pages, and if you know somebody who wasn't able to register for the event, please ask them to go to the LinkedIn pages for that live stream. If they're unable to make it, there's still hope. The event is also being recorded, and you can find a copy of the event on the Conversation Africa's playlist on YouTube tomorrow. So the conversation has a YouTube channel, and on that YouTube channel, the Conversation Africa's playlist will have the event details. Now, we'd like you to share your insights and your thoughts on the discussion today on social media. If you do share your thoughts on social media, we'll ask you to use the hashtag tackling health crises, hashtag tackling health crises. And please share your thoughts and ideas on us on social media. Last but not least, there is a Q&A. If you have questions for the panelists, please feel free to share them in the Q&A, and Prof. Gostin will share them with the panelists at the correct time. Thank you so much for joining us. I'm going to hand over to Prof. Gostin now, who's going to take the discussion further. Prof, over to you.
Thanks very much, Candice, and welcome to everyone in Africa, the United States, and around the world. We're really delighted to have you, and we have an incredible program today. I'm going to just set the scene briefly and then introduce our highly esteemed panelists. Um, the African continent is undergoing a number of significant health threats at the moment, and as we know, they have for some time. The Africa CDC and the World Health Organization in the Africa region have been remarkably impressive in trying to tackle these crises. Currently, as we know, there is an Mpox outbreak. A global outbreak of Mpox began in May 2022. It does continue to this day. Recently, we've seen a major outbreak in the Democratic Republic of Congo, which has spread to many neighboring countries, including Burundi, and with rapid increases in Uganda. We, at the same time, have seen a Marburg outbreak in Rwanda, where Rwanda has confirmed more than 60 cases of Marburg, but it's acted with resolve, with a very strong health system, strong capabilities, and that Marburg outbreak now looks contained in Rwanda, demonstrating a highly effective response by that government and also Africa CDC and WHO. Finally, there, as many of you will know, there have been an undiagnosed illness in the DRC, in a rural area of DRC with over 400 cases, um, uh, uh, with many with flu-like symptoms and 31 deaths. A large number of cases are among children 5 years and younger. It's a remote area, so it also suffers high levels of malnutrition and low vaccination coverage, leaving children vulnerable to a range of diseases, including malaria, pneumonia, measles, influenza, and others. Now, all of these three overlapping health issues come at the backdrop of major challenges of Ebola over the years, the global COVID-19 pandemic, and of course, the ongoing and very serious HIV/AIDS pandemic. What's at stake in Africa and globally? Um, well, I think these multiple outbreaks demonstrate significant limitations, including restricted global access to medical countermeasures, including diagnostics, personal protection equipment, therapeutics, and vaccines, as well as ample funding for research and development of these medical countermeasures um, uh, by an independent African continent. Um, the prolonged outbreaks are barriers to development, socioeconomic equality and security, and the impact of delivery on all health services, including community health services um, and um, community medicine, as well as community thriving. Um, in our interconnected world, as we saw so vividly with COVID-19, HIV, Mpox, Ebola, that these health emergencies have both local and regional matters of significance, but also can spread quickly globally around the world. Um, we have a number of processes ongoing in Geneva and in other capitals. One, of course, on June 1st this year, the World Health Assembly adopted a reformed international health regulations. And there's currently ongoing and serious negotiations uh, on a pandemic agreement, a treaty on pandemic preparedness and response, with Africa and the Africa Group playing an enormously important role and pushing, particularly for what I regard as the most important thing in global health. It's really the heart of our field, which is fairness, equity, and justice. We are really truly privileged at the Conversation Africa and the O'Neill Institute at Georgetown University to have Africa CDC and the World Health Organization regional office in Africa here today, along with truly world-class panelists who have been global health heroes for many, many years. We had planned on having the Director General, Jean Kassé, from the Africa CDC. Um, uh, he informed me just this morning that he was called away to deal with a major issue on the continent. And so I thanked him for his service, and I really want to make a special thanks to Dr. Raji Tajudeen, who's the Deputy Director of Africa CDC, a medical doctor with advanced degrees in pediatrics and public health. He's a fellow of the West African College of Physicians and the African Public Health Leaders Fellow at Chatham House in the UK. I also want to introduce, a global health hero, Dr. Matshidiso Moeti. She's regional WHO regional director for Africa with almost 40 years of national and international experience in public health. And she joined the WHO regional office in 1999. My longtime friend, Dr. Ashish Jha. Ashish is the dean of Brown University School of Public Health, and he served honorably and really, in my view, spectacularly as President Joe Biden's White House COVID-19 response coordinator. And then two of our very own, Matthew Kavanagh, director of Georgetown University Center for Global Health Policy and Practice. Matt has served as the deputy executive director ad interim at UNAIDS. And so he has enormous experience in the AIDS world. And Kashish Aneja, who leads initiatives in Asia at the O'Neill Institute and supports its Center for Transformational Health Law. So we're going to begin our panel discussion. What I'd like to do now is invite our two Africa colleagues to begin by giving us a situational update of Mpox and perhaps others. What's happening now? What are the demographics at risk? What is the single biggest challenge? And WHO and Africa CDC working to respond. What are the resource challenges that you see? So I'd like to start, if I can, to invite Dr. Tajudeen to begin, and then go to Dr. Moeti. Can you please put on your cameras?
Yeah, good afternoon, colleagues. Let me start by thanking Georgetown University for inviting Africa CDC to be part of this discussion. Let me also seize the opportunity to, tender Dr. Gian Kesia, the DG of Africa CDC's apology. He actually planned for this, but again is in Abuja, and he had to be pulled away for another high-level meeting at a very short notice. So he has asked me to step in for him. And let me also greet the fellow panelists. Allow me to recognize in a very special way Dr. Moeti, who, as Lawrence rightly described it, as being a pillar, as far as public health or global health on the continent of Africa is concerned. And let me also use this opportunity to salute her for the enormous work, that has gone into building a resilient health system across the member states on the continent of Africa. Now, having said that, colleagues, ladies and gentlemen, as of today, let me start with the Mpox. 20 countries, reported Mpox since the beginning of the year. In the past 6 weeks alone, 17 countries have reported suspected cases. And if you go back from the beginning of the year, talking of January 2024, we're currently in week 48. And as of week 48, we have a total of 65,711 cases, talking of both confirmed and suspected cases. Sadly, 1,231 people have actually succumbed to the Mpox. And Central Africa region, talking of the geopolitical regions of the continent of Africa, account for 92% of cases and 99% of deaths. And the DR Congo remained the epicenter, of this Mpox outbreak, and 75% of cases actually from DR Congo, and 99% of deaths, of the total Mpox deaths on the continent have been reported from DR Congo. Let me also state that 6 member states have moved from reporting active cases to control, a situational control stage of the outbreak. Talking of Gabon, the Mpox is largely controlled for now. Guinea, South Africa, Morocco, Zambia, and Zimbabwe. And 2 member states have moved from control stage to actively reporting cases, talking of Congo and Ghana. So overall, the WHO and Africa CDC have revised, the public health emergency declaration that was issued on August 13 by Africa CDC and August 14 by WHO, talking of the public health emergency of continental security and public health emergency of international concern. So when these 2 situations were reviewed, it was agreed that, from advice from the scientific, experts on the continent, that the Mpox still constitutes a public health emergency. So we cannot declare it being over. Allow me to shift here and talk a little bit about the demographic distribution of the Mpox and cases. Children below 15 years of age constitute between 35 to 45% of cases. And in some settings, in fact, the percentage is much more than this 40% of cases. When you also look at the distribution, we observe that sex workers, the men who have sex with men, truck drivers, people in congested areas, especially the IDP camps, also constitute, significant proportion of the Mpox cases. And of course, people who by way of their occupation interact with the wildlife also constitutes a significant proportion of the Mpox cases. And in terms of gender distribution, the females are disproportionately affected, talking of 54% of cases. So let me stop here, Lawrence, and hand over back to you. Thank you.
Thank you very much. And what you were talking about is that when the original Mpox outbreak was formed, for the very first time ever, the Africa CDC declared a public health emergency of continental importance. And the day after, Dr. Tedros at the World Health Organization declared the outbreak a public health emergency of international concern under the international health regulations. Dr. Moeti, do you want to add to the situational update also to bring in the role of WHO in the African region?
Yes, thank you very much indeed, Dr. Larry Costin. And I'd like to start by thanking thanking the O'Neill Institute and Conversation Africa for having invited me, WHO, and my colleagues to be part of this very important conversation. I'd like to greet all the panelists who are here with us, particularly Dr. Ashish Jha, whom I've met in the past on travel on mission to the US. I think Dr. Taj has given a very comprehensive and great overview of the situation of Mpox in the region. What I would like to say from the beginning is that, as you already mentioned at the beginning, Dr. Boston, this Mpox outbreak, as well as the Marburg disease and this new outbreak of this respiratory disease in the DRC, occurs in a context where countries are already faced with recurring disease outbreaks, with climate-related public health emergencies, and of course, with human crisis due to conflict. I mean, I think one can say, just to give an overview of what that situation is like, that in the region at the moment, we have 151 public health events, of which 114 are disease outbreaks, and that includes Mpox, and then 37 humanitarian crises. And essentially what this means is that the same health systems that you've mentioned, the same health workforce, the facilities and resources are having to handle multiple challenges. Post-COVID, we've had outbreaks of measles because children weren't being vaccinated through the lockdowns, and really quite very high numbers of children dying of measles, and have had to support working with our partners countries to mount campaigns against this. So this gives, in a way, the context of this Mpox outbreak, which serves as an example of what is needed, what are some of the challenges, and what are some of the actions that are being taken, and the progress being made, but the huge gaps and challenges that remain on the continent. So Dr. Taj has summarized the situation in terms of epidemiology, the numbers. Very important to remind ourselves, of course, is that Mpox is endemic in some countries, in some Central and West African countries. Then on top of that, the situation has come this recent upsurge of cases due to new variants of the virus. The situation in terms of numbers has already been provided, been shared. And really, the epicenter of all this, as was said, is in the eastern part of the Democratic Republic of Congo, with subsequent spread to neighboring countries, to Burundi, Kenya, Rwanda, and Uganda. And then we've had occasional cases also of the clade 1B spreading to other parts of the region and internationally, of course. I think what's very concerning is the degree to which children have been impacted, and the types of high-risk, vulnerable communities, people who are engaged in sexual networks. Just to emphasize that part of the DRC not only is a place where there is kind of conflict, but it's also an area, and many displaced people. It's also an area of intense population movement because of the mining industry there. So those are really some of the drivers of vulnerability among the people concerned. So we've seen also the spread of the clade 1B, particularly affecting sex workers, also children, to other groups, mobile groups, people who by their profession, by the way they earn their living, are extremely mobile and also are living in very, very close contact. So I think it's really to emphasize that it is a moving situation, and linking to your introduction about equity, it's in a way a very serious challenge, but it's also an opportunity to pay attention to a situation of endemicity that has been happening in the background. And it's the triggering of a global outbreak and now a regional outbreak that's really focused the attention on this disease, which is increasing, as we are told by experts, as time moves on since we stopped providing smallpox vaccination. Therefore, it deserves attention going into the future as we see evolution in the countries, in the region, in terms of population movement, connectivity, and very much going back to the issue of equity, to the issue of strengthened health systems, preparedness, investment in the health systems when we don't have a pandemic or an outbreak, and therefore having the capacity progressively being built institutionally, human resources in the health systems to be able to be prepared for and respond to the example of the Mpox outbreaks and the many other outbreaks that are occurring in the region and on the continent.
Yeah, I mean, you've really highlighted, multiple challenges. It's not just a virus, but you've got weak health systems, conflict in the DRC, mass movements of individuals and close interchange with wild animal populations, and of course a lot of children, particularly being malnourished and underserved. So to both of our African colleagues, are there any what do you think of as the major challenge now? And do you feel that continental resources are being worn thin, dealing with multiple health issues simultaneously, or are there any synergies? Do you have for example, the vaccines that you need for Mpox? Talk a little bit about what you see as the major challenges going forward. Raji, did you want to begin?
All right, no, let me go first. So no, thank you, Lawrence. And I think Dr. Moeti has already talked about some of the challenges. So let me use DR Congo situation, as a way to respond to your question here, because I mean they account for by far the majority of the cases of Mpox on the continent. So the first major challenge as far as this Mpox situation in DR Congo is concerned is the low capacity for testing, lack of adequate lab infrastructure, and lack of the system, to really transport some of these samples from the remote areas to where we have the labs that can test these particular samples. And of course, even the workforce capacity, is also, quite suboptimal as far as DR Congo is concerned. And so also for most of the surrounding member states where we currently have the Mpox circulating. For instance, in DR Congo today, the testing rate is somewhere around 30 to 40%, which is quite low if truly we want to bring this situation under our control. When you also shift here and go to contact tracing, for Mpox, we expect that for every single case of Mpox, at least we should be able to trace around 20 contacts. Today, what we've been able to achieve is around 3. So meaning that there's so many chain of transmissions going on there that we don't even have we don't have visibility of what those chains of transmissions are, and without proper contact tracing, it becomes very difficult to be able to, bring this outbreak under our control. When you look at surveillance as well, this is also a big challenge, as far as the Mpox situation on the continent of Africa is concerned. Surveillance system remain very weak. In fact, only 9 of the 20 member states are consistently reporting on Mpox. We also have challenge in terms of data. Real-time data collection is a big issue. In fact, when you talk of movement of data from the subnational to the national level, even within the same country, is a big issue. Risk communication, community engagement, is also a major challenge, as far as this outbreak is concerned. Funding is a big issue. As we all recall, at the margin of the UN General Assembly, that was September this year, the African Union, through the Africa CDC, convey our head of state and government and partners, to mobilize resources to control this Mpox. And in that meeting, and through other engagement, I think we've been able to mobilize around 1.1 billion USD. But of this 1.1 billion USD today, only a quarter of that has been disbursed, so which leave a very big gap, and really, a very big issue in terms of having adequate resources to be able to put, to bring this outbreak under control. And for colleagues, just to also bring this to perspective, at the outset of this, the response, the continental response that was jointly put together by WHO and Africa CDC, we did develop a continental plan that was costed, and the cost of that is around 599 million USD. So today we have not been able to mobilize that to bring this Mpox outbreak under control. So a couple of challenges in there, in addition to what Dr. Moeti did mention early on. So let me, yield the floor back to Dr. Moeti. Over to you.
Yes, and then I'd like to bring in Ashish, Matt, and Kashish. Dr. Moeti, did you want to respond?
Thanks. No, I think Taj has done a quite good, given a quite good overview, really, of the resource and capacity gaps that still exist in the countries. One thing that one might add is also to see how to have some consistent and more effective use of the available resources. We know that there are competing priorities, multiple outbreaks, other health problems to be dealt with. There's consistent investment to try to build the surveillance systems, and this has been going on for a couple of decades in Africa now, but they still are not yet up to the task of dealing with situations in predictable ways. I think what really is needs looking at more closely is how to have pulling together of some of the major resources that are being invested in health to deal with different diseases, to deal with disease outbreaks, preparedness and response, and also to deal sometimes quite separately with health system strengthening, while emphasizing the connection between preparedness, capacity at the primary care level. There's a lot of discussion these days about community health workers. And in my view, this needs to translate, expand into community health systems, of course, with health workers, human resources there being very important. But what happens at the most peripheral healthcare facility and how it's connected using some of the technology that could be available today with the system in order to alert quickly, early rather than late. I think that some of what's going on today around mobilizing resources for health system strengthening needs to be connected intentionally with what is going on with preparedness and response to disease outbreaks. The institutional capacity building, which has been very interesting in the past few years in Africa, putting in place public health institutes and having some consistency and continuity in the capacity building are extremely important in my view. I do think that some important conversations going on about the Lusaka agenda, which is linking the major global health initiatives for HIV, for immunization. I really do think we need to be putting disease outbreak and epidemic preparedness and response into that conversation so that we don't have an additional sidelined conversation about really the connection among all of these. I mean, just to say that the one opportunity is the pandemic fund, from which we worked with our member states together with the Africa CDC, and were able to mobilize resources for pandemic preparedness and response. And some of the countries, the DRC and other countries that are involved in these outbreaks, are going to benefit from these. So I think it's just institutional capacity building, health system strengthening, making effective connections, and of course, very importantly, paying attention to the issue of equity of access to the key tools at the international level and seeing how to make that available in predictable ways so that countries can know what it is that they will be getting and invest themselves. National investment as well as international support is also very important, because sometimes it can be more flexible and applied to the situations as needed. Thanks.
Yeah, well, thank you, Dr. Moeti. You've raised a nice transition to not just the role of the continent itself, but also the important role that we play as an international community. And so I would like to bring in Ashish, Matt, and Kashish to kind of really reflect on the kinds of resources and capacities we need to bring Mpox and some of these other outbreaks under control globally. And, what do you see as the major global risks? How do we mobilize funding in a world where competition for funding is fierce, as we saw with the WHO investment round, the underfunding of the World Bank's pandemic fund, the inability to really come to grips with a sustainable funding mechanism in the pandemic agreement. Ashish, do you want to start with you? Then we'll move on to Matt and Kashish.
Sure. First of all, Larry, thank you for having me, and really the Conversation Africa. Thank you for hosting this. It's an extraordinarily important discussion, and Dr. Moeti, great to see you again. So thank you, everybody, for this event. Let me lay out a couple of things that I think are important here. We're seeing this sort of, I think, a uptick in types and numbers of outbreaks really around the world. I mean, we're seeing it on the African continent, and that obviously is a focus of today. But there are these global trends that are driving this. Obviously, climate change is one of them. Obviously, on the African continent, the dynamism of the continent, the amount of economic activity, growth, means people are moving. And more human activity, more movement, more economic growth also, unfortunately, means more outbreaks that go from local to regional and then ultimately global. So I say that as a way to say this is going to be the new normal. And we have to deal with a world where this is going to be the new normal. The other big challenge I want to lay out, and then I want to talk about where I think we can make some progress, is, and I just want to call the elephant in the room out, the US is about to undergo a very substantial change in its leadership. In about 6 weeks, the Biden administration will be stepping off and the Trump administration will be coming in. I've spent a lot of time in the last few weeks talking to people who are in the transition team for the Trump administration. And the debate, and I worry it's not even so much of a debate, but almost a fait accompli, is the Trump administration basically leaning very heavily towards pulling out of WHO and pulling out of these multilateral organizations. And of course, you will not be surprised. I think that would be a catastrophic mistake. It would be a catastrophic mistake for the global community, it'd be a terrible mistake for the United States. But I don't hold as much sway with that group as I wish I did. But so in that context, I think we have to really think hard about how do we make progress on these really important issues. Where I am optimistic is I think we have seen, again, I think the rise of the Africa CDC is to me a very, very positive sign. I think the way Rwanda handled the Marburg outbreak is a very positive sign. We are increasingly seeing African institutions, African countries gain capacity and manage these outbreaks more effectively. And the international community has to find a way to continue to be supportive, even if some governments are going to withdraw from that. Maybe the last quick point I'll make, and I'm sure Matt and Kashish will want to jump in and we'll have really important points, is that there are places where we have real innovations that we have got to be able to drive. So, we have a vaccine against Mpox. When we had the Mpox outbreak in 2022 here in the United States, we deployed the Jynneos vaccine. It was a very important part of getting that outbreak under control here. That vaccine has existed. The US government funded it. We have to get, Mpox has been endemic in the DRC for a long time. We need to, even when there are not major outbreaks happening, we need to have a very concerted effort towards getting that vaccine out to the highest risk populations. And I think we have, as a community, not done enough of that. There was a long period between late 22 and then 24 when we saw the resurgence of 1A and 1B. It took too long for us to get these vaccines out. And we've got to do a better job on our front on that. And the last point, and it has been brought up, is so much of this stuff gets under control if we are able to do basic, kind of what I think of as old-fashioned shoe leather epidemiology of being able to identify cases, do the tracing, do the isolation. That combined with vaccines and treatments is how we get outbreaks under control. That's certainly been the experience with Marburg, with Ebola outbreaks in the past. And there, I think we need some real innovations. I still think our testing, not only is laboratory testing capacity not great, we need to develop rapid tests. I've been talking to people in the, who are on the front lines in the DRC. When you think about, sex workers or let's say long haul truck drivers who might stop off at a health clinic, get tested. If the results aren't back for 2 days, that person is long gone. Identifying that person, figuring out who their contacts were, is no longer possible. Rapid tests at the point of care is going to be really important part of developing this. They're often cheaper, they're often easier to deploy. So there's a lot of work to be done in the biomedical area as well. So yes, investments in public health, investments in the health system, investments in vaccines, but I want to see more investments in rapid diagnostic testing because I think that's an important part of all of this. I'm going to stop.
No, thanks very much, Ashish. You've really brought in some really important factors, including rapid testing, but also I think given the world's movement toward kind of a more isolationist position, including in health, is concerning. I just came back from Berlin a couple of days ago with the German government and the European Union. And given the headwinds from the United States, they themselves are not in a good position to step in to fill resource gaps, and I wouldn't expect them to do that. So Matt, you've got a lot of experience with UNAIDS, and of course, while we've been spending most of our time on Mpox and a bit on Marburg, we've got still a major crisis in Africa and other parts of the world on HIV/AIDS, Ebola. We're still reeling from the effects of COVID-19 and the loss of trust. What's your take on all this?
Thanks. Pardon. Thanks, Larry, and thanks very much to Conversation Africa for partnering on this. And hi, Dr. Moeti. Hi, Dr. Taj. Nice to see you, both of you, and thanks for taking the time. So, I mean, a couple of things. I mean, one thing that I think is really important to remember, and this is vis-a-vis the Mpox outbreak, is that this is one of those that potentially could have been stopped, right? So we had a situation where I remember being in Geneva in December of 2023 for a set of meetings, and WHO had just reported, I pulled the number as I was getting ready, 12,569 suspected cases of Mpox in the DRC. Africa CDC had actually been reporting, rising cases since January of 2023, but they weren't lab confirmed. And so one kind of piece here is to think, okay, how do we increase that lab capacity? But the other is to ask, why didn't the world actually think deeply about that and trust that actually some of the best pandemic response and infectious disease thinking in the world is in the DRC. These are folks who are brilliant. So if they've got 12,000 suspected cases, my guess is there's a serious problem. And so thinking deeply about kind of what that looks like for the world, I think is really important, because instead of doing as what Ashish was just saying, right, which was to deploy the vaccines that we knew had helped stop the outbreak elsewhere, right? That by May we were actually ending the fake internationally because of how effective those vaccines had been. But instead of that, what happened, right? So US CDC at the time issued an announcement to Americans to be careful because officials should be on the alert for clade 1 virus that might spread. Instead of issuing a local response to that, there could have been an international response, and yet there weren't any vaccines that were deployed. And so I think Ashish is right there that global response mechanism really didn't work. And so kind of what are we doing right now? Well, we've got a vaccine distribution mechanism that's primarily based on donations. So the request has been somewhere around 22 million doses that are needed. So far, we've only had about 5 million doses committed, many of which have not yet arrived. And this is a kind of strange moral issue to be in, because the reason why this isn't working is that, okay, during COVID, we might have possibly had a debate between, should US and Europeans vaccinate their entire populations, or should they be sharing doses? But at this point, we're actually talking about, vaccines that are actually kind of held, right, for future outbreaks instead of being deployed for a current outbreak. And that, I think, tells us that not only are we in a moral quandary, but we're really at a governance challenge, and we've really got some missing pieces. And so to me, that says a couple of things. One, it says we really have to move away from a kind of charity model and a vaccine donation model, and instead toward a model that says, where is the pandemic infrastructure? How is that going to be resourced? How do we locally produce around the world vaccines, medicines, diagnostics in a really serious way? And hats off to both WHO and Africa CDC for really leading some of that thinking. And then how do we ensure that high-income countries are sharing technology instead of promising to share doses? Because whether you look at the HIV pandemic, you look at the COVID pandemic, and now you look at the Mpox pandemic, where literally the decision is, there is no Mpox outbreak, nor is there a smallpox outbreak in high-income countries, and yet still donations are not happening. So, that tells us that we've got a political something that's broken there, right? Because countries are afraid to share stockpiles. They don't want to do it. There's a variety of kind of mechanisms there. So we've got to figure out some kind of other sharing mechanisms, which I think means sharing technology instead of kind of a model of donations. The other two things I would just flag, one is, we've got to be thinking about kind of community-based pandemic infrastructure. So hearing Dr. Taj thinking about kind of, who's most at risk, thinking about sex workers and others, I do think we should look to the HIV response. So, what's interesting is if you look at the DRC, there's higher viral suppression rates on HIV in the DRC than in the United States, right? 90% of PLHIV know their status, and almost everyone that knows their status is on treatment. So that says that this is possible, right? And you've done a few other things, but the community infrastructure has been funded on HIV in a really deep way. And so you've got groups like Humana People to People in Kinshasa, and you've got Umande that's working with sex workers and others in the DRC that are really mobilizing that community-based infrastructure that's able to better reach high-risk people, that's better able to tailor interventions to local needs, that can kind of focus on where are the inequalities like the marginalization of sex workers. And that's pandemic response. And I think we've got to think about that. And then the final point I'll just make is we've really got to rethink our funding piece here, right? So, I really note that the point of a public health emergency is to mobilize public attention. And I think it really has done that in a big way. But it hasn't mobilized the dollars, right? I mean, WHO put out an $88 million ask just recently and is not getting the response that it needs. Nor can it turn to the pandemic fund because the pandemic fund is not for response. And so we really do have not only a failure to mobilize that, but I think we've got a failure of the mechanisms, right? And so I think thinking about a set of kind of non-voluntary mechanisms about how we mobilize that money so that, for example, the emergency funding that's available can really be triggered much faster has got to be a top priority, because we're now into at least pandemic 5 in the last few decades, where funding has not been able to be deployed in the way in which it needs to be, and the mechanisms we've got still, despite a lot of work, are not where they need to be.
Yeah, and we're very likely to be seeing more crises emerge, whether it's in Africa, Asia, or Latin America. We don't know, but we need to be prepared for it. One of the things you mentioned, Matt, which I think all of us have thought, is that the dominant model of charity for a vaccine and other kinds of donations seems to be lacking, because many of us know that these resources always come too little and too late. And so there's a really big push to get independence in low and middle income countries and in different regions around the world, including the African continent, to produce their own vaccines, diagnostics, therapeutics. And that's really going to be crucial. We're going to need technology transfer. We're going to need a lot of investment. Kashish, you and I wrote an article in the Hindu about this, and particularly looking at the role of India and the Serum Institute and other strong manufacturing capacities in that country. Do you want to talk a little bit about how the international community can be more resilient when these outbreaks occur, including sufficient access to technologies?
Thanks, Larry, and thank you for having me over. And thanks to Conversation Africa to organizing this extremely amazing panel. I feel honored to be here. So, picking on what Matt said as well as Dr. Ashish said, we've realized from the COVID-19 pandemic that we simply cannot rely on donations and the goodwill of high-income countries as well as pharmaceutical industries located in high-income countries. It's clear that self-sufficiency is the key moving forward. The key to self-sufficiency or local manufacturing capacities is technology transfer. The underlying problem with tech transfer is that this involves transfer of technology, know-how, as well as skill set, which often includes intellectual property as well. What we routinely see is that, to an extent, developed countries and the manufacturers are actually comfortable sharing technology as well as the patent behind it. But where the negotiation actually stops is the know-how. And without actually having the know-how and skill set to develop the vaccines, you can't do much with patents. And we saw a similar thing with the mRNA tech transfer hub that WHO established in South Africa. I mean, one of the reasons why the entire negotiation stalled and why it was hard to actually bring it up was because of the lack of agreement from some of the vaccine developers to share the relevant know-how required to manufacture the mRNA vaccine. To that extent, specifically in context of mRNA, Ashish mentioned the Genus vaccine, which has been available in the EU and the US for a long time. It's a vaccine developed by a Danish manufacturer, Bavarian Nordic. And So that particular vaccine uses the chick embryo fibroblast CEF cell cultures, which is also used in vaccines for measles, mumps, and rabies. There are over 11 manufacturing capacities in LMICs, 3 of them in India. For example, the Serum Institute of India and the Bharat Biotech, which played a significant role during the COVID-19 pandemic. These 11 manufacturing facilities in LMICs have experience and expertise as well as existing supply chain to handle CEF cell-based vaccines. So technically, they're well equipped to do so. But what is actually stopping them is, of course, the transfer of technology, know-how, intellectual property as such. And so I mean, I read this quote somewhere that it is the sharing of knowledge rather than just the doses that distinguishes charity from justice. And that's where I would say the key lies. The second important point I'd like to mention here has been the regulatory concerns at the domestic level in a lot of LMICs. While the vaccine was available in the global north, the reason why a lot of the domestic regulatory markets were not able to introduce was also because of a lack of harmonized regulatory environment during emergencies. Some countries, for example, Uganda, also lack the standard emergency use authorization frameworks, which can act as a hurdle to actually introduce the vaccines in the market. At the same point in time, clinical trials also take a long process of time. With the lack of EUA authorizations and the lack of legal infrastructure in place domestically, it can add to the problem. There are other important regulatory concerns to be looked at also, including indemnity and liability issues. That's also where the negotiations stop when it comes to sharing of vaccines. Also, how to manage off-label use as well as the shelf life of a particular vaccine. There's also often seen the lack of communication between regulatory authorities and the healthcare workers when it comes to the shelf life of a vaccine itself. I'm going to stop there.
Yeah, thank you very much, Kashish. I mean, you do raise a really crucial issue concerning regulatory capacities. You know, it's important for us to recognize that it was only fairly recently that the DRC had given regulatory approval to the Mpox vaccine, and this was one reason for the delay, and that was years after the U.S. FDA and the European Medicine Agency had already approved the vaccine. The WHO itself, I think, was a little bit slow in trying to get pre-qualification, which would have helped speed regulatory approval in African countries and other parts of the world. So what I want to do is now get some conversation, turning back to Dr. Taj and Dr. Moeti. Give us a sense of what your perception is of the role of the international community, and what you see as the challenges to getting access to these medical technologies, as well as the challenge, what your hopes and dreams are about more self-sufficiency on the continent, so that in future health emergencies, the continent itself can produce the kinds of response, medical and other response tools that it needs to really take control of this, particularly in a world that is becoming much less, having much less solidarity, much less international cooperation with the rise of populism. I'd love to hear from our two African colleagues on the interrelationship between Africa and the international community. Dr. Taj, did you want to begin, and then we'll go to Dr. Moeti?
All right, no, thank you, Lawrence, and thank you, Kashish, for that brilliant, remark, around issue of local manufacturing. So again, if you look at the Mpox situation, access to medical countermeasure is one of those key issues, that those 20 member states of ours, currently facing in terms of challenges, to bring this Mpox under our control. Local manufacturing capacity for vaccines, for therapeutics, for diagnostics. Today, I did mention that DR Congo is only able to test, around 40% of the Mpox, cases, 40% of the suspected cases is what DR Congo has been able to achieve. And there is no way we can bring this outbreak under control without adequate testing. And for us to be able to have adequate testing means that we need to have adequate diagnostics, in terms of number and in terms of distribution. So I think for Africa CDC, we continue to push this agenda of local manufacturing, as articulated and as mandated by our head of state and the government, talking about the platform for harmonized African health product manufacturing, and the procurement mechanism. And for us to be able to do this, I think, one, we need to be able to have what we call the African-led clinical trial or research agenda. And in this space, I think we need a lot of capacity, to be able to do that. Number two is the aspect of regulation, which Kashish has brilliantly articulated. And for Africa CDC and African Union, as you are all aware, we have the African Medicine Agency, which is being operationalized as I'm talking to you now. But for it to be fully operationalized, what we've started doing is to work with our WHO colleagues, to be able to look at how do we strengthen the regional centers of excellence for regulation, talking of institutions like AVAREF in West Africa, so that they are able to support, the member states within the different geopolitical region. And tied to building the capacity of those regional regulatory centers of excellence is also support the national regulatory agencies. Today, we know that a couple of our member states have been able to achieve the maturity level 3. I think the two most recent ones are Rwanda and Senegal. And before that, I think we had around we had around maybe 6 or 7 of them, on the continent of Africa. So we're working to support the national level regulatory authority, the regional level, and of course, the Continental African Medicine Agency. Of course, we welcome all sort of support to be able to really build that capacity. Number 3 is the tech transfer, which Kashish has brilliantly articulated. I don't want to go into that space, but I think without this tech transfer, there is no way, we can be able to move at the right speed as far as, this local manufacturing, agenda is concerned. Number 4 is the aspect of investment, the right investment. Today we know that Africa CDC working with Gavi Alliance, we have the African Vaccine Manufacturing Accelerator, that's actually earmarked close to $1 billion USD, to support manufacturing, local manufacturing agenda. But Gavi alone cannot do this. So I think investment from other global players will surely go a long way, to support this local manufacturing agenda. Number 5 is around market shaping, because I think one of the biggest incentives to build the local manufacturing capacity is to have that guarantee that once those products are produced, there is a ready market for that. And I think one of the ways to start this is to make sure that as we advance our local manufacturing agenda, we work with the global partners to ensure that whatever that is going to be used on the continent, certain percentage will be procured from the local manufacturers. And some few years back, either state and government did, put, their foot on the ground to say that 40% of vaccines, to be used in Africa should be procured from the local manufacturers. Again, this will only be possible if the global players, talking of Gavi, talking of UNICEF, you really begin to heed this, directive or this mandate from our head of state and our government. So last but not the least on this is to say that there is no way we can guarantee security, sovereignty, of our member state without a very strong local manufacturing capacity for those health security products, talking of vaccines, talking of therapeutics, talking of diagnostics. Let me stop and hand over to Dr.
That's really important. Really important. I'm very glad to see the commitment by the continent, in particular Africa CDC, to that kind of independent ability to create your own research and development around medical countermeasures. I think it's going to be important, but it's also challenging, as you said, because we've also got problems of how we're going to force companies to share their technologies. We've got intellectual property issues, and we've also got major investment issues. We've got about 1 more minute before I want to go to audience questions. Dr. Moeti, could you just reflect on how you see this from WHO's point of view and what the role of WHO's regional offices and its office in Geneva is for this?
Okay, thank you. I'm not sure I can do it in 1 minute, but I'll try my best.
No, I'm sorry.
I think just going back to regulatory capacities and the role of the institution that's coming into place, and we're very happy about that in Africa. I think this is an area in which there's been huge underinvestment for decades in the region, and so it needs to emerge very strongly, and not only from the international organizations, but from local organizations. I mean, I'll just tell you that for our vaccination program, funded by the Bill and Melinda Gates Foundation and working with regulatory authorities around the meningitis vaccine that was developed, we've had one person for quite a few years funded by the Gates Foundation working with the regulatory authorities. And the investment at country level, including by the global health initiatives that are supporting some access to tools work, has been really under-recognized. I think it's only now that the importance of regulatory institutions is emerging as being very, very important as we are looking at the issue of local production. And for me, it's something that really needs prioritization within national budgets, prioritization by international partners as well. And of course, at WHO, we'll be doing our best to play our role in pulling this all together in terms of decision-making around tools to be used and tools to be procured and provided by the global health initiatives. I mean, I think Dr. Jha mentioned financing challenging within the geopolitical context that is emerging, and so did you, Dr. Gostin. So to me, what this drives is what Taj has been referring to, what the African countries at the political level need to decide upon themselves, because even the local manufacturing agenda really faces the challenges of scale, number of countries intending to produce, investment, and rationalizing all this so that it becomes, in the end, a good investment for this patchwork of 55 countries, many of whom are initiating local manufacturing ideas. So that really needs political discussions that are going to rationalize the investment and make this affordable and make this cost-effective for the countries, for the investors, and for the partners that are going to support this. So that conversation, in my view, is very important, even as we have institutions emerging. At the end of the day, because we receive in WHO requests to support local manufacturing from a huge number of countries, and I'm always wondering, so who's trying to rationalize and organize this? In my view, that's a political conversation. And it's a responsibility of our political leaders to delve into this quite challenging issue.
That's a brilliant point, really. I mean, what you're saying is that politically, countries have to step up, make the investments, make the commitment to do this. It can't be casual. You can't have somebody come in and do it for you. The countries have to do it themselves. I think that's really good. I'm going to now transition to audience questions, and we've got a number of them. The first one is for Ashish Jha. Ashish, what can we learn from Rwanda's apparent success in responding to Marburg? As we know, Rwanda has quite a robust health system.
I mean, it's a great question, and it is a reminder that that these things are manageable and they're controllable. And Obviously, what Rwanda has done has taken years of work and investment in building up one of the very best healthcare delivery systems on the continent, one of the best public health systems. Close to, I think, 90% of people have access to health insurance. And then I think the other part of this has been the speed with which they responded to the outbreak and mobilize the global community. And I think there's a set of things that Rwanda has done that absolutely should be part of the playbook that we can replicate elsewhere. By the way, not just on the African continent, around the world. I mean, I think Rwanda's investments here and Rwanda's actions. And so I do want to make that point that it's not just about the money, which of course is important, but it is also the ability to execute on the policies, on the strategies that is so important. And I like when I think about the Marburg outbreak in Rwanda, there wasn't. I mean, there's no magic sauce of they didn't have some vaccine that no one else had, but there is an experimental vaccine that they were able to get into country very, very quickly.
Yeah, and they
Um,
deployed it.
and they deployed it. And the speed with which all of that happened is, I think, the most important lesson to learn here, because we have seen this in other outbreaks where it takes far too long to bring things in. And infectious diseases punish you for being slow. And that is a place where I think, I mean, Rwanda deserves credit, I think, across a range of issues, but that is a place where I think they deserve particular credit, the speed with which they were able to move on these issues.
Thanks very much, Ashish.
If I may say something about
Yes,
speed.
please do. Please do.
I mean, I agree very much with Ashish. I do think one of the, and I don't want to refer to specific disease outbreaks where we see countries hesitating to declare that there's an outbreak because they fear the knee-jerk reaction of being locked away. So we do need that confidence in a rational international response to declaring an outbreak. That's what enables countries to be fast in being open, declaring, initiating action. I mean, I do agree that Rwanda is quite special, and a basic investment in the health system is very, very important. That's why I'm insisting we can't just talk Lusaka agenda about HIV and vaccination. Let's open it up to disease outbreaks as well, because in a few years we'll be talking about this. We need to do it now. Sorry,
Yeah,
something like
these
that.
are just, these are, really important questions that are ongoing in Geneva. I mean, what you're referring to are the targeted travel restrictions, sometimes trade restrictions that took place. For example, South Africa was, for doing a good thing in reporting a variant of COVID, got socked with was the Omicron variant, got socked with travel restrictions, and that's something, a governance issue we need to deal with. I'm going to come back to the
Can I
pandemic.
just make one quick point on that? I apologize for interrupting. Just, in the Rwanda outbreak of Marburg, if you remember, that was about 6 weeks before the US election. There was actually intense political pressure inside the US to try to do something about travel restrictions and really clamp down. And I think I'm very happy that largely did not happen, because of all the negative effects that will have. But it is incumbent on all of us to put pressures on our own government not to do those things, because the easiest politics in the short term is put in travel restrictions, put in trade restrictions. And all of us have to make the case for why that is bad for the country in the short run and really bad for the global community in the long run. So that is a responsibility that we have collectively that we have to exercise.
Yeah, and it impedes the response. So it's kind of a really different mindset. The next question, I'm going to come back to Kashish and Matt on the pandemic agreement and how they see this fitting into all this. But the next question is for Dr. Taj. Given the dramatic gaps in testing, would it be possible to ship samples from other countries to support the DRC and Burundi?
Thank you, Lawrence, for that question. So the issue here is most of these cases are actually in the remote areas, and Many a times, the time it takes to get the sample from those remote areas to either Goma or Kinshasa, where you have those labs, by the time the sample gets there, then it's no longer, good for any meaningful test to be carried out. So I think the easiest and the best solution here is to decentralize testing, at the level, at the national to the subnational level. And one thing that Africa CDC has been trying to do, though quite challenging, is that we know that in most of these member states, they have a lot of gene expert machines, that's been used over time for TB and other, outbreaks. So what we need to do is to work with those some of these companies to provide or to produce the right cartridges so that we can comfortably decentralize testing. Also to get some qPCR machines, some of those that are quite portable, to get them to those at district level. So the easiest way to go about this, honestly, is to decentralize testing, because even if you want to shift samples across border, it also has its own challenges, and the issue here, especially in DR Congo, is to get the sample from those remote areas, to the capitals, that is where the challenge is, and if you're able to successfully decentralize testing, I think it will go a long way to really assist in terms of the testing rate, in the Congo. So let me stop here.
Yeah, so I've got a number of questions coming in from the audience that are really good. I think I want to, given the time, I want to end with the pandemic agreement. So I'm going to go to a couple of set of questions to Dr. Moeti first, and then invite Matt, Kashish, and Ashish to conclude reflecting on the question around the pandemic agreement and the IHR. So I've got two questions for you, Dr. Moeti. I think I'm going to pose them together. The first one is about wastewater surveillance and the role that it plays for guiding a targeted response to Mpox and other diseases, and also for Dr. Moeti and Taj, if it's helpful. Some African countries see foreign aid in the pandemic response as a form of foreign influence and control. And how can we address this perception to enhance the pandemic response? And so try to kind of reflect on those two things, if you could, starting with wastewater surveillance, which is becoming quite important with COVID and a whole range of other diseases. This question is aimed toward Mpox. Dr. Moeti, do you want to start first?
Okay, I'll start at a bit of a disadvantage. I'm not aware of the details about wastewater surveillance, specifically around Mpox, but that's clearly an area that needs more emphasis and investment more generally in order to be able to get a broader picture of what's going on and to be able to get data about some of the organisms that may be around. It needs more investment and more emphasis. And then in terms of the discussions that are going on and the pandemic negotiations, the pandemic response as foreign control, I do think we're at a stage in the discussions now where it's more important than ever to find a way of identifying the world as interconnected and interrelated as it is. Because as we get closer and closer to issues of equity, issues of sharing of resources, sharing of technology, capacity to produce and to ensure that the interventions and the tools that are needed are available as they are needed at the most crucial time all over, and to balance the benefits versus the investment of different types of countries. I think all of this is getting to a very crucial stage of deciding whether it matters that we share a common faith and how we're going to express that in our actions and our investments as a global human community. and I don't want to take long, but I'm reminded, I worked in HIV, and I'm so reminded of the conversations around access to HIV. So I find it really unbelievable. I was the HIV manager in Botswana when it was the worst affected country in the world. I worked as the head of the Africa desk in UNAIDS. So these are recurring conversations. What will it take to take that shift in step of agreeing that we need to mutually contribute what we can contribute, and then share common faith in terms of the surveillance, and reassure those who think this is all about controlling people, controlling freedom to accept interventions, vaccines. So I think those conversations need to happen from the political level right down to the community level, and different people who increasingly have different beliefs. It's crucial.
Yeah. And, I think HIV really changed the world. And it was something, there's so many lessons we can learn, particularly about bottom-up community, demanding for their health rights. Dr. Raj, did you want to say anything about the wastewater surveillance or some of the other things that Dr. Moeti said?
Yeah, no, thank you. And just to complement what Dr. Moeti has said, let me start with the wastewater surveillance. So wastewater surveillance definitely is another tool, that adds to, the current, surveillance landscape as far as the continent is concerned, in terms of early detection, early warning, and all those things. I think wastewater and environmental surveillance is quite critical. But we need to understand that as far as the continent of Africa is concerned, this is a relatively new area for us. Therefore, there is need to really build our lab infrastructure to be able to make the best use of the benefits, that coming through the wastewater surveillance. We also need to build the necessary capacity, on the continent of Africa to make the best use of wastewater surveillance. And of course, we have to find a way to integrate whatever data that is coming through, the wastewater surveillance into the larger data, so that at the end of the day, it's all about public decision making, just not, something for academic exercise. Emphasis should be on public decision making. Now, around the issue of foreign aid, Dr. Moeti has talked extensively around Lusaka agenda. How do we bring foreign aid together with all those global health initiatives, within the Lusaka agenda, so that at the end of the day, we have what we call the one country, one plan, one budget, one report, and by so doing, you are catalyzing or you are supporting the member state, you are putting the member state at the forefront, of whatever that foreign aid is coming to support, so that it's not an imported solution, it's a local solution that the foreign aid seeks to sort of support. And again, the foreign aid should also be viewed in the context of localization. Whatever foreign aid is coming, you should also try to build the capacity, of our own local implementing partners, because a situation whereby whatever foreign aid, 40% of that has already gone into indirect costs, of the implementing partner from the global north. So at the end of the day, the impact, is going to be watered down. But if we truly want the foreign aid to have an impact, I think two key agendas here, the Lusaka agenda and the localization agenda, need to be fully supported, and it should be incorporated within those two agendas. Let me stop here. Over to Lawrence.
Okay, thanks very much. What a rich and robust discussion, and particularly about the need for, building surveillance capacities and testing capacities on the continent, including wastewater, but not exclusively. We've only got 5 minutes left, and I want to bring in the whole panel here. And let me just invite first Kashish, then Matt, then Ashish, to give some closing reflection remarks. And if you can, bring in a little bit of your vast experience about governance and the international health regulations, the pandemic agreement, whether or not you see any of the processes in Geneva as it really providing, important governance and other support for these ongoing outbreaks. Kashish, do you want to begin?
Thanks, Larry. So specifically in context of the pandemic agreement, I think it does 5 critical points which are of significant help to us today. First, in context of One Health, it's going to be for the first time that the One Health principle is going to find place in an international legal instrument, and that's going to be significant in terms of operationalization of OH in domestic laws and policies, given most of the problems which we are dealing with are zoonotic in nature. Second, pathogen access and benefit sharing. The pandemic treaty also introduces pathogen access benefit sharing in the form of an international multilateral instrument, which will be governed by the WHO. Of course, there are debates about what percentage of vaccines and therapeutics should be contributed or not. Third, in context of technology transfers, it dedicatedly tries to introduce tech transfer in context of know-how, skill set, as well as technology, and making it mandatory in nature. But realistically speaking, I think we're going to get stuck with voluntary tech transfers itself. In context of intellectual property, it introduces a clause known as a peace clause, which basically says that certain countries should not pressurize other countries in order to use TRIPS flexibilities, which in the past, which we have seen, has been a hurdle. And finally, the pandemic agreement has a reasonable implementation mechanism up until now in the form of the conference of parties, but it still requires a significant strengthening to that extent. We're not sure if we'll have a pandemic agreement by the end of next summer, but even if we don't, I think it actually acts as a perfect blueprint for regional instruments, which I personally feel is actually the next way forward. Thank you.
Yeah, that's really fascinating, because particularly now that we've got a new administration in Washington, whether we're going to see the culmination of the pandemic agreement by the World Health Assembly in May of 2025 is unknown. But thank you for those, really 5 terrific areas of how the pandemic agreement could promote things. And also, I love the idea of a regional agreement, particularly in the African continent. Matt, you've got vast experience in governance and on response to these issues. What's your thinking?
So thanks to everybody for a really interesting conversation. So, I think one is just to say that the actual political bargain here is really clear, right? That on the one hand, we need to share technology and funding, and on the which is what low and middle income countries are asking for, and on the other hand, the sharing of data and surveillance. And that is an obvious political bargain, and yet we're a bit stuck, because we're stuck at a kind of middle level, and we need actually some high level political engagement. I wish what we saw was probably that coming. I'm worried that that's not what we're going to see. Perhaps the only positive thing of if the U.S. decides to withdraw from WHO is that perhaps that will pave some way, and maybe political consensus can be made, because I'm deeply worried about a withdrawal. I think that's obviously a terrible idea. But I also am very concerned that the U.S. has not been a mover on kind of striking this, especially around some of the technology transfer pieces, right, and some of the funding pieces. I'll just say 2 things on this. One is on tech transfer. This is not rocket science, right? We saw in COVID, Moderna did tech transfer. They just did it to themselves, right? So they hired Lonza and set up entire new factories, right? Shared technology transfer wasn't a problem. Dr. Moeti was mentioning the AIDS response, right? There, we've seen a model, right? That's about governments exercising their legal authorities, pushing companies to share technology, and then funders coming in to make it happen. We have models for where this can work, and we just need to use them. So it needs to be, I think, in the pandemic treaty, something that's along the lines of some commitment to actually share transfer, because if you leave it to the private sector, we are never going to get voluntary transfer. It's never going to happen. Sorry to be the bearer of bad news. Has yet to happen. I do not expect it to happen. Governments are going to need to actually use their legal authority to make it happen. And then final piece that I'll just say is, on the question that you asked about governance, Larry, the other piece that we've just got to make sure is that we figure out how we have a compliance mechanism, right? The fundamental thing that we're talking about here is there are lots of commitments not to do things like impose travel restrictions, and yet governments do. Part of what we need is just a governance mechanism where countries can actually argue this out, right? And so things like dispute settlement mechanisms can actually be hugely helpful, because then South Africa can raise a flag and say, sorry, this is not okay, and actually has to come together. Same could happen on the sharing of technology. So introducing some of those things as the Conference of Parties could actually make this a governance mechanism that ends up not being compulsory, but instead a cooperative governance way of dealing with pandemics. Thanks.
Yeah, that's really important, Matt. So much there, and particularly the idea, whether governments will have the political will, going back to Dr. Moti's point, to actually require that kind of technology transfer will be, really crucial. Ashish, I want to give you the last word here. You've got so much experience in the White House and globally. Reflect on what you've heard today, where you think things are going, and then I'm going to close it up and turn it back to the Conversation Africa to play a closing video.
Thank you, Larry. No easy task to try to reflect on what I think has been an extraordinarily rich discussion. I will say a few things. I mean, I said this a bit earlier, but we really are entering an age of biological threats, both both natural as well as man-made, and we have to basically, as a global community, get our act together in building better surveillance, diagnostics, better medical countermeasures, better engagement with community. We know the playbook. We know what needs to be done. The complexity has been, how do we effectuate change? I see not only the US almost surely pulling out of WHO, but I think you made this point earlier, Larry. I don't see other countries stepping up in a substantial way. If we avoid that, the U.S. is not going to lead on trying to get us a pandemic agreement. That is just, I don't see any hope for that under a Trump administration. In that context, the question is, where are the solutions and creative ideas going to come from? They're going to come from, I think, a lot more South-South partnership. The world's largest vaccine manufacturer is not in the global North. It's actually India. And tech transfer from Serum Institute and Bharat Biotech, but certainly Serum should be on the table. And so the kind of old world of global North and global South is about to get shifted in some very substantial ways. And we all need to change our thinking. I think a lot more innovation continues to come from the global South, and partnerships have to come within the global South. And I think if we can do that, there is no question in my mind that we can manage the time period that we are going into. But I do think our international institutions are at some risk of being stuck in an old mindset. If we can make that transition, it's going to be forced on us in some ways by governments, like the likely moves by the Trump administration. Let's figure out how we live in that world and build more secure health systems. I think we can, but it's going to take all of us to think differently about what those mechanisms are.
Well, thank you very much, Ashish. What a brilliant summation. This has been just a remarkable discussion, and I think, it leaves us with a lot of worries, particularly about the where we're going as a global nation, and our interconnectedness, and our ability to really, share resources, share science, in the way that we need to kind of make those enormous advances. But then again, optimism. And I think the optimism that I see are just these remarkable leaders, like Dr. Taj and Kashish and Dr. Moeti on the continent, that really will lead that, and including South-South partnerships, which can be very exciting and break the mold of charitable contributions that we've seen before. I really want to thank the Conversation Africa, and just a remarkable panel for their insights. It's really been a great privilege for the O'Neill Institute and for me personally to moderate this. And now, Candace, with deep thanks and gratitude to you and your team, I'll hand it back over to you.
Prof. Gostin, thank you so much for moderating this discussion. It was such an insightful discussion. It was wonderful. I could actually keep you guys on my screen forever, but I think I have so many questions. But thank you very much to Dr. Moeti, Dr. Taj, Dr. Ashish, Kashish, and Dr. Kavanagh for your insights. It's amazing. Thank you so much for being part of it. And thanks to the O'Neill Institute for partnering with the conversation. Colleagues, just to remind you that you can find this event on our YouTube channel, and to remind you to sign up to the Conversation Africa's newsletter so that you can stay on top of all of Africa's biggest issues. Thank you so much for your time today. Have a good afternoon.
Thank you. Bye.